You're listening to
CRST,
the podcast
from Bryn Mawr Communications.
Hello, and welcome to another episode of CRST, the podcast. I'm your host, Eric Rosenberg. I'm a cataract, cornea, and complex anterior segment surgeon out of Long Island, New York, and Site MD, also assistant professor of ophthalmology at New York Medical College. On this episode, we're exploring the transformative potential of digital technology in ophthalmology as featured in the June cover focus of Cataract and Refractive Surgery Today, for which I was honored to serve as the guest medical editor. As co-founder of the Digital Ophthalmic Society, I've witnessed firsthand the power of AI, machine learning, and teleophthalmology as tools that enhance workflow, improve patient access, and elevate the standard of care. Joining me for this discussion is one of the contributors to the June cover focus, Dr. and Professor Oliver Findel. Thank you for being here. And before we get started, maybe you can help by introducing yourself, Professor Findel.
Oh, well, thank you very much, Eric. Oliver Findel, I'm in Vienna, Austria. I'm chairing a department here in Hanusch Hospital. We have a research group as well called Vienna Institute of Research in Ocular Surgery. I also currently serve as the president of the European Society of Cataract and Refractive Surgeons, the ESCRS.
Well, it's fantastic to have you here today, and thank you for joining. We are all immensely looking forward to joining you in Vienna, Austria for ESCRS this year. It's poised to be an awesome meeting, and I've been getting a lot of the mailings here, and just kind of jumping into it, we're seeing a lot of digital medicine going into it, and it seems as though, as president of ESCRS, you've wholeheartedly embraced this digital ophthalmology, existence and why it's going to be so important. So maybe you can tell us, why this was such an important attribute to including in ESCRS this year, and it seems to be much more prominent now than we've seen in the past.
Well, absolutely. I mean, things have changed significantly over the last few years. Being also part of the Digital Ophthalmic Society, which you invited me to be part of, also helped. I think we formed a digital committee last year because we thought that would be in place and necessary for the next few years. And actually, Bruce Allen from Moorfields Eye Hospital is chairing that, and he's very enthusiastic. And we've also now had a digital ophthalmic grant, which we gave out this year actually to studies which are done collaboratively on keratoconus actually, and using AI to try to better detect keratoconus. And that is going to be an ongoing program over the next few years. This grant program. And so obviously we wanted to have digital to be really part of our program at the Congress as well. And what we did is now we have a digital track. So we have a research symposium on digital medicine on Saturday, and then we have essentially 4 sessions concerned with digital ophthalmology on Monday, the whole Monday. And we call it the Digital Monday actually because of that reason. And that's starting with looking at digital health in different continents, so the different societies, also the American Society of Cataract and Refractive Surgeons, the ASCRS, as well as the Asian Pacific, and us. We do this together in a symposium, and then we have quite a bit on the digital operating room, and then also on robotics, because that's also digital in a way, right? So where are we going with robotics in the operating theater? And then the afternoon is again sort of similar to your Digital Ophthalmic Society day, but just obviously much more compact. Another session in the afternoon. So I think if you're interested in digital ophthalmology, that day will start at essentially pretty much at 8:30 and lead until 4:00 in the afternoon, and you're pretty much always digital during the day. So, and we're trying not to be repetitive. So I think it's going to be quite interesting. Yeah. So I think why are we doing this? Well, there's no question that is going to be part of our future, and it's probably a very important part of our future. And there's a lot of opportunities there, a lot of interesting and fascinating things happening. and trying to just get people also to be sort of sorted, to understand, what different parts are. You have AI, you have robotics, you have, obviously big data, and all these topics are sort of swirling around, and they're sort of, to a certain way, they're also interconnected, and I think that's what we're trying to better understand. What is the current standing of all these?
Absolutely. I love that with Bruce and Hirschnall, right, and the team at Moorfields, that, in talking to them, I've always been very excited hearing their take, and their existence, or how they see the integration of some of these tools as we proceed with ophthalmology, and really stepping up to bat to kind of be the foundation player, to help us create, a universal type system, that, we can start, modeling, the digital health and digital ophthalmology after. So it's been exciting seeing them move in this space and what it is that they're doing. And that kind of leads me to the next point, where it's very interesting to see all these societies going across the APTOS, the ESCRS, the ASCRS, really embracing these digital platforms, because it used to be that they were placed in different subcategories, right? You'd have like an AI talk in glaucoma about how it was being used to, study the nerve, or telehealth and telemedicine in a cataract discussion, or better yet, a diabetic retinopathy. The one consistency here is numbers, right? People and biology, that all changes as we go across the globe. And we really recognize that early on, 50, 100 years ago, with the varying pathologies that we see in the incidences for those pathologies. But numbers, they don't change. And we can really start to work together again with these digital platforms across all of ophthalmology and all of medicine, not just sub categorized like we've been doing, in kind of carving out these niches. We need to start working together, I think, in order to tease out some of these important pathologies that exist across the platform, and how things play into each other. And, I guess that's a good prelude to, talking about the power of big data in ophthalmology, and, where we can see leveraging some of these data sets, and how we're going to incorporate that going forward. And I think you're working on a very interesting project, as has AAO, with the IRIS registry, and maybe you can elaborate a little bit more on those.
Well, I mean, we're not doing an iris registry in Europe at the moment, and I think the problem is manifold. One is it's a very resource intensive thing. To do something like as huge as the iris registry, which is done in the US. Number two, we have different languages, different cultures. That makes it a lot more difficult. Also, we don't have the same legislature, right, in all these countries. So that means, there is sort of one common, GDPR for data protection. That's Europe wide. That's fine, and that's not really the issue. That's not the problem. But also that I understand in the US, iris registry worked because people really have to sort of have to have an EMR, right? And here they can also have to have they don't have to have an EMR, they can, and there's still people who write on paper here. I mean, doctors, colleagues of ours, and hospitals, which are still on paper, because they know that EMRs are also painful in a certain way. To get them installed, they're expensive, they cost you a lot of trouble. So as you know, there's a lot of issues, and so doing the iris registry, that's something which is probably much easier to do in one large country than to do it in multi countries. Number one. Number two, the problem, I think, we also do a registry, the EUREQUA registry. I think it's out there since nearly 20 years. And that is the European quality and assessment for cataract surgery, and was originally designed by Mats Lundström, and it came from Sweden, from the Swedish registry, and was sort of and with EU funding, the ESCRS created EUREQUA. And EUREQUA has, I think, more than 3 million cataract surgeries on board. And there are some countries like Sweden or the Netherlands who play nearly all their surgeries up into that registry. And there are other countries which are sort of participating only to a small extent, or some, this one clinic, that university, whatever. And that has given us a lot of benchmark data for PCR, posterior capsule rupture, for risk factors and for outcomes, of course. But the problem with that is it doesn't have very detailed information. So it really has, obviously the preoperative, intraoperative, some postoperative, that's it. So there's visual acuity, any complications, stuff like that. But obviously not more than that. So no real biometry data, for example, or no, tomography data, no scans, nothing of that kind. So really the question is, what do you want? You can, if you want to develop, for example, AI, or you want to develop some algorithms, whatever it may be, you can either have a lot of data like Iris, just looks all across the country, but maybe not to such a detail. There's not really necessarily images there. There's not necessarily any raw data there, meaning, tomography data, for example, or biometry data with all the details. Or do you want to have a smaller data set, which can still be a large data set, but just much more compact, where you say that that's really well structured, very well defined data, like a data warehouse, and then you can have that data set, and then you can start doing all kinds of hypothesis testing or whatever you might want to do. Develop calculation formulae for IOL power, whatever it may be, and so I think we're not quite sure where we want to be. I think for some things you need the big data approach, the sort of registry approach, and for others you may actually need a well-selected, well-done, well-made data set, which is really has high quality, has high granularity, and then that can really help you. And I think that's what we're sort of aiming for at the moment, is to go for these smaller, still large, but smaller data sets compared to big data, and then try to have those as well formed as possible. And I think that's going to be, to be honest, all this AI stuff. I'm not an AI specialist. I've never done AI, let me say, programming. We don't really, using AI algorithms. But really, my understanding is the most important really is the data which is behind it, and then I think that's what we're lacking in many cases. That's, for example, where Medical Retina is a lot better than us, because they have all these OCTs already, right? And it's pretty much all done with 2-3 different types of machines, and then they can just go ahead and they have obviously these vast all these injection patients come in and out and come, and so those huge data sets, and also data sets they have from the big from the trials which are used for the new drugs, and also there the reading centers, they have huge data sets of images. And I think that's obviously for retina, that's great, because what they, I think, will be able to do quite soon is to say, see things which we can't see, and say, not only don't I see that in that OCT, but the kind of specifics you have in that OCT, even though we don't know what it is, actually is a good or bad prognostic factor. And that is a patient who's really going to be good for that kind of treatment, or for another kind of treatment, or you can change intervals quickly. I think all these things will be coming in medical retina pretty soon. And I think that's where we're a little behind in anterior segment surgery at the moment, because we just don't have such let me say, coherent data sets.
And that's a great point, and that brings me to another point of this discussion. I get a lot of questions as to why now, right? We've had digital technologies in ophthalmology for quite some time. Why is that existing now? And I think you touch on it very clearly. And we're really on a cusp of having to understand what questions we need to ask and how we need to ask them. And with what you're bringing up, physicians need to learn the nomenclature behind what we're studying and how we're leveraging machine learning and artificial intelligence. And what you were just touching on is essentially adaptive AI versus generative AI. So adaptive is the more traditional one that we're used to, where we're having these large data sets and we're leveraging the machine learning and the artificial intelligent algorithms to be able to process what it is that we have in our databases. And if we want to break that down further, we can start talking about federated data, which is really new on the scene, where you can query certain databases and ask them different questions depending on what the database is in order to get a similar result. So you don't necessarily need to have consistency going across the board. You can pull in data sets that exist in different metadata categories across the board and then be able to pull them in. Now, the question is, how clean are those sets? That's always been the question. So garbage
Rubbish in, rubbish out.
Yeah,
Old
exactly.
story, right? Rubbish in, rubbish out. There you go.
For sure. How clean are those sets? And then are we asking, the right questions with those federated algos? So we need to be able to appreciate that. Now, let's go back a little bit and talk about generative AI, which is also new on the scene. And it focuses on using unsupervised and semi-supervised data sets in order to produce new content. However we want to be able to produce that content. So the problem with the generative AI is that we can also see drift mechanics, where it starts to drift off of the original question, so to speak, and it formulates its own answers and responses based on the previous sets because it's unsupervised. When you start having a little bit more semi-supervised, the generative algorithms, then yes, right, we'll see a little bit more homogeneity with the answers that we're receiving versus those drift mechanics. But these things didn't exist 5 years ago, right? Or at least not in medicine, for sure. And I think that drives home the importance of why clinicians and any provider, for that matter, really needs to start understanding the mechanics behind what it is we're looking to integrate into ophthalmology. Like you were saying, I think it's important for clinicians and doctors to understand the AI algos that underpin, all the technology that we're looking to unveil, because we can only do what we know, and blind faith in anything has never proven to be a strong prognostic indicator of success. So we need to, and we have been obviously formulating and developing programs at our national meetings and international meetings so that we can serve the broad group in terms of helping them to understand. So understanding is one thing. I'm curious how you see how you see some of these technologies underpinning what it is that we do on our day to day, and how it's going to help to improve patient care through these digital technologies.
I think most of us don't really need to know. I mean, it's good to know the nomenclature and to understand the systems in principle, but I think most of us will not be using AI, or not be sort of using it in a form that we will be generating an AI algorithm. I think we may, some may want to do that. That's fine. But I think at the end of the day, what we will have, we will have products from companies, of course, because we need something which we can. We need for documentation. We need medical devices at the end of the day, right? Software, also medical devices, and I think that's and we'll see some of probably the big players are going to be the ones who will be, on the forefront there at some point, and these AI algorithms will have learned from large data sets, and they will still be learning as things develop. And I think that's where we're going to be heading. So we'll probably have, this app and then that special app and that module that, which is inside of our whatever, for example, OCT machine and what it may be. And we'll have that obviously probably for IOL calculation. But I think, I think what's also important is and I think from a certain perspective is what maybe interests me even more than having these small apps here and there, which are going to be very helpful, I believe, is to have something which sort of really puts your EMR together. You have your EMR, you do all these patients, and you enter the data either in a structured form or sometimes even just with free text. And there's even some pretty good algorithms now which even understand free text and obviously do searches for free text. throughout your whole EMR, where you've have your thousands of patients which you're taking care of. And I think we'll need it'll be very useful for us to do audits to understand our quality of service, to understand our outcomes. And I think patient-reported outcomes is something we're doing much too little of. For example, for cataract surgery, we have problems out there. There are short questionnaires. Do we use them on a regular basis with every patient? Most of us don't. So I think we'll see that coming much more into play, and then to really understand, which patients are unhappy and which are happy, and for good reasons or for not for good reasons, and to really understand much more of this complete, let me say, a little more holistic, even though still ophthalmic. I'm not talking about completely holistic, but trying to really better understand, and also beforehand seeing that this patient may be a patient who's at risk of not being happy, because we've had that kind of pattern already in the past in several patients, and it's popping up again. And I think these are things which would be very, very helpful for us also in our daily routine, and not just diabetic screening in fundus photographs. That's also great, especially for internal medicine specialists or GPs. But really, and of course for OCT and stuff like that, it's going to help us. But I think that's also going to be of quite a bit of interest. And then, of course, last but not least, also surgery, and that's obviously what and many of us are most interested in. And the question is, whether you're just sort of doing your cataract surgery, you just sort of, and then suddenly the algorithm says stop, because there's some kind of pattern which you're doing. Either it's because you're tired, or it's because the eye looks the way it looks at that point in time, where he says, oops, this is a potential issue you're going to have right now. There's a high risk, there's a risk of, I don't know, 90% that you're going to run into some kind of problem now, because you've had that already in the last 5 years, 5 times in different cases, but which looked similar. I think so. So this will, I think, maybe something quite fascinating, I would think. Something which is sort of watching your autopilot, the autopilot who tells you, you're sort of going a little off the normal offbeat track now, and you just have to watch out. So I think, I think we'll see some things coming like that. I think, and I think that's something which is quite could come quite sooner than we think.
You touch on a great point too, and it's one of my favorites in digital medicine and AI-backed patient care therapeutics and diagnostics. It's not about asking the questions we know; it's about asking the questions we don't know, and it's unique ability to be able to digest and interpret data at speeds previously not recorded, through multimodal mechanisms to be able to provide us with a different vantage point than we're used to having, which would only further enhance, the patient care therapeutics and diagnostics. So I love that idea, right? Going into cataract surgery and it processing data in real time, understanding fluid mechanics, which we appreciate, right? When before you sit down with a phaco needle, you need to read certain books, right, to understand the machines that you're using. And yes, in principle, it's there, but the means in which for us to in real time appreciate variances is not to the same standard that we can use AI and certain therapeutics and certain algorithms. But let me transition just for a second and welcome Grayson Armstrong, who we're privileged to have here as well today. I'll let you introduce yourself and then ask you the same question, where we're talking about improving patient care through digitization, and more specifically in your case, the concepts of teleophthalmology, what benefits, challenges, and future prospects you'll see with those platforms.
Well, thanks for having me. This is awesome. And I'm Grayson Armstrong. I'm an eye surgeon over at Mass Eye and Ear, Harvard Med in Boston, Massachusetts. I practice as a complex cataract surgeon and medical retina specialist and have a very strong interest in digital health and telemedicine. So thanks for the easy toss-up question for me. Telemedicine has a few obvious benefits, in my opinion. Telemedicine being defined as kind of caring for a patient through some digital mechanism from afar. And whether that's a video like a Zoom screen, like we've all been living on over the past couple of years during the pandemic, or whether that's something more robust, with analytics and imaging incorporated, we're trying to use technology to broaden the gap and make it so that you don't have to have a doctor and a patient sitting in the same room at the same time. There is a future where we would be able to evaluate a patient as good or better than we could right now in our slit lamps and with our indirect ophthalmoscopes um, using digital mechanisms. But unfortunately, for a lot of ophthalmology, that's not the case today. So if you're able to implement telemedicine in a meaningful way, you can raise the ship in terms of education and diagnostics across all countries and across the world. Everyone would get the same level of care because everyone would be able to share the same diagnostic platforms, the same AI algorithms that Oliver is, so well versed in and working on, and everyone would benefit from the same technological advances. And you could have specialists from one country consult another and say, "Hey, we just need your help on this. Can you pop in real quick and give us your advice?" And in addition, it would help education because not all countries have the same educational paradigms as we do here in the United States and in Europe. And I think that some countries would really benefit from that. Patients would be able to kind of have ease of access in their homes and in their communities instead of driving sometimes hundreds of miles in the Midwest of the United States to try to see a physician. But there's some real challenges in setting this up. Right now, if you're setting up telemedicine on a phone call or a video call, you may not get a really high quality exam. You might be able to see a sty and you might see a preseptal cellulitis, but you're really not going to be able to find that retinal tear on a Zoom call. And you're not going to be able to diagnose, AMD bleeds from the comfort of your home. So we need some help with that. There are some people thinking about this. There are individuals who have proposed a novel model of care called hybrid telemedicine or hybrid ophthalmology. It's partly asynchronous, meaning that you can get the pictures and photos of an eye as you would in your clinic anytime you want. The patient can come in and get their OCT, visual field, their topography, and whatever field you want, and then they go home. Subsequently, they hop on a call with me or you or anyone, and then you can review those images in real time with the patient, make a diagnosis just like you would in the office, and send them off. Eventually, if we had anterior segment imaging, that might help too, because right now it seems to be the laggard in what we use clinically in a meaningful way. Everyone uses an OCT and retina, but how many cornea providers take anterior segment imaging on a day-to-day basis? It's limiting. So there are some improvements that could be made. But overall, if you can do that model, then everyone can get really high quality care. If you can incorporate machine learning algorithms and AI, then the screening can be done for you. You can also use telemedicine and digital health to try to collect the HPI and pass medical, pass surgical ahead of time, and offload a lot of that work for you as well. So there's a lot of benefits from this. And looking forward, I think that as the tools evolve, as the models of care evolve, it's really up to us as clinicians to make sure it's safe and effective and it's the same quality care. It's really up to us as physicians to make sure that we're giving it to the right patients, because not every patient's going to be a good candidate. If it's not every patient, for example, is really good enough with their phone or their computer to set up a Zoom call even. Some patients just can't do that right now. So we can be thoughtful about it, but ultimately there are some benefits to society that will come with time.
Grayson, absolutely. I'm completely with you, and especially if somebody has to travel far. But I'm just wondering, if let's say somebody has to travel 25 minutes to get to you, and they could do it from at home, but then wouldn't you really also, don't these patients also need some personal contact? I'm especially with, I'm talking about elderly patients, and if they're alone at home and then they're alone again, and actually we know that when they sit in the waiting room, some of them like to wait. Why? Because they talk to other patients, and then they talk to you, and they talk to the nurse, and they talk to your front desk. And of course, we've all had that patients who, you give them a diagnosis, or they've already been given a diagnosis beforehand, which is not a good one. And then you can also actually hold the hand. And even if you just do that for 10 or 20 seconds or whatever long it is, that has some impact for the patient and may actually do them well, may even do them better than the next injection they get. So I really wonder. We also we still have to be aware that it's not only about looking at OCTs and sort of essentially looking at the cataract grade and doing the surgery, but there's a lot more to it. And we in ophthalmology, we are quite detached from the patients because we have that slit lamp in between us, usually, most of the time, right? And so we're not as close as others are because we don't have to touch them usually. But I think just because we're ophthalmologists and we're sort of used to being a little detached already, We just have to watch out that we don't detach even more. And I know, for example, at Moorfields, they do that. They do these clinics, which patients go to tech-driven clinics for glaucoma, for medical retina. They get all the imaging, and then everything is read 2 or 3 days later by a consultant who's sitting in front of two screens. And obviously writes, everything's good. I mean, I think it's technically sound, but I'm just wondering whether this is the way, patients actually really want it. I'm wondering.
That's a great point. And there's going to exist a problem in the U.S. where there's a mismatch between the number of providers and the number of people who need care as well. So, the question is how to bridge that gap best. And I think you both touched on those points very eloquently, because we're at a crossroads between implementing more, I don't want to say uneducated providers, but less well-trained and less well-qualified providers, maybe to augment our extended reach. That would be able to do some of the things that you mentioned, Professor Findle. And then at the same time, allowing somebody in a satellite campus to be able to study and analyze it, like Dr. Armstrong's saying. There's going to probably be a hybrid of those two approaches too. And I think, medicine, in my own personal opinion, has always started and ended with the patient-physician relationship, independent of anything else. And I think to be a good physician, it behooves you to remember those points. But the question maybe should be, and this one's kind of looking towards that future, what implications do AI and big data have for ophthalmology? How do we leverage it to enhance and not replace? So I can't remember if it was Ted Lang or Yannick Leiterman who said that he doesn't like the nomenclature artificial intelligence. He much prefers augmented intelligence, something that would be able to enhance, not replace the things that we do on the day-to-day basis. I'm curious how you see those future implications of AI being incorporated into our day-to-day lives.
Yeah, I mean, the machine learning aspect of this is interesting because it is I like the term augmented intelligence as well. In fact, the American Medical Association uses that kind of as its term instead of artificial intelligence. They've adopted that in a meaningful way. It is meant to help support us and make better decisions. And there are patterns within data that humans just can't find. There are pictures of fungi that can show things that I can't see as a medical retina specialist. It can tell you someone's age and gender and can tell you what their hemoglobin A1C is, their creatinine. The things that people can find in photos or OCTs is pretty remarkable.
Dr. Armstrong, I mean, are you not a good clinician? You don't know somebody's HbA1c from a fundus fund?
Unfortunately, I'm not trained enough. I need to go back and do more training. But it's funny because you can get a lot of systemic information from these photos. And so you could imagine a future where instead of going to the lab, you just get a photo. They can tell you a lot of these metrics. That would be really cool, wouldn't it? And then ophthalmology is the gatekeeper of the rest of the body, and we can really get some useful systemic metrics. And we're just kind of at the forefront of it all. We'll see if that ever comes to pass. It's a dream and a hope. And back to what you were saying earlier, I hope and pray that this doesn't replace the physician-patient relationship. I hope that there are patients that if they need it, they can find us. But there are those patients that really don't have transportation. They're stuck at home, whether that's from socio-demographic factors. They need to take care of their elderly family member or their kid. And I'd like them to get the same access to care that the patient sitting in my waiting room has. And ultimately, everyone's going to need something unique. And I think that really does speak to the patient-physician relationship. We can just broaden our reach with new modalities to the right patient at the right time. And it shouldn't be blanket for everybody.
I think, let's say you really want to be efficient, and we probably have to become more efficient because the baby boomers are getting into the age where they're going to have disease, and we're not getting more physicians. In Europe, at least, there's a tendency to having less physicians, also because of baby boomers going into retirement. And so what I expect is that we're not going to have these Zoom calls with these patients. I think that's not going to happen very often because, as you said, they don't know how to work Zoom, or then they don't get in at the right time, or you don't, so you have these short time slots, and it's going to be, I think it's something which you may do here and there for special patients, but it's not going to happen very often. So I think what is going to happen is they're going to get an email or they're going to get a letter which says that's your diagnosis and you should see us immediately, or you should see us in 6 months, or you should see us in a year's time. And it's just going to be quite offline, I think, and that communication is going to be a very strange communication, I believe. Theoretically, you can play this through the GP, for example. That would be an option in some countries where the patients have a strong adherence to the GP, and you play it through the GP. That's okay, maybe. You could play it through some other, healthcare professionals, like optometrists, maybe to a certain extent. In some countries, that also seems to work quite well. But I think still, for our role, it's a tough one. If it's just about screening, I'm absolutely with you. But if it's really about patients who actually have a disease and who otherwise see their ophthalmologist with a certain, on a regular basis for good reasons, I'm a little worried about that kind of, doing that on a large scale with, for these patients quite intensively. Just wonder where they end up.
Well, given that you both have been in the metaverse, and I probably need to ask this question, right? Do you see VR, AR, mixed reality coming into play both, at the clinical level and at the professional level? I mean, we've started to see a little bit of it at the professional level, but do you think we'll wind up seeing medical storefronts or mechanisms or means in which to be able to interact with those patients that, as Grayson alludes to, may not have that access to care, and maybe they do, right? And this would act as that first in between, your office and the discussion with the patient. Would there be a play there that you would say?
I'm probably too old for that already.
I don't think there's such thing as that. And you've been in the metaverse, so you definitely can't play that card.
I don't know. I think we really probably have to wait for another few years to really see whether that's going to, be something for mainstream for many people. And probably, and the more technical it gets, the more gadgety it gets, then also people sort of lose it. So I think it has to be pretty simple and pretty straightforward. Maybe, yeah, I wouldn't rule it out.
The first cell phones were so complex and bulky that only the richest and the most, well-versed patients or people in the world could have them. And now we all hold something with more computing power than we can imagine in our pockets. I think early on, AR and VR was a novelty for gaming, for imaging, and for a few things. And I think that with Apple coming out and talking about immersive computing and really beyond just the gaming space and really beyond some of these early use cases, I think that there is a potential that this could be used at scale at a point where people feel like they're engaging with one another in a new way. And I'd like to see that happen because it would give that personal touch to some of the computing that we're doing right now. I don't know that it's going to be tomorrow. And I think that there's a bell curve of humanity on every device uptake. And I think that we're currently on the leading edge of that. And it's going to slowly trickle down to the middle and beyond. So it's exciting to watch. And I'm glad that people like you, Eric, are helping shape what that looks like. And I think that we'll all benefit. I think that there's currently a small percentage of humans that would take advantage of that in a meaningful way. I can say personally, having been in the metaverse and creating memories with people having stood virtually side by side, it feels like we were together, even though I was sitting in a bedroom in my pajamas. And it was pretty wild to look back at that and like, oh yeah, I remember that. Like, even though the moon was in the background, I feel like I got to hang out with Eric Rosenberg. That was pretty fun. So it was.
I'm sorry in advance that you had to hang out with me. That was definitely the penalty.
But I think there could be a future there.
Well, great. First and foremost, I appreciate both your times with doing this podcast here today. It means a lot to me, and I know to everybody listening. It's definitely a novel topic and discussion. It's not going to end here by any stretch of the imagination, and it's really exciting to see these societies embrace what the technologies are and what they're going to be, and to be as progressive as they've been. I really commend ESCRS and ASCRS and the APTOS for really being progressive leaders And it shows throughout history. Every step along the way, they've always been progressive with whatever the technology was at the time in ophthalmology, to be able to embrace it and be able to deliver it to our patients in a meaningful way. So as we conclude this discussion, it's clear that the future of our field, to me, in my personal opinion, lies in leveraging AI and machine learning technologies to ensure a more accurate, efficient, and customized patient care, given our discussion here. The promise of AI and big data is undeniable, as is the importance of careful and responsible implementation. So on that note, I'm Dr. Eric Rosenberg. Thank you for joining us on CRST, the podcast. Don't forget to read more about these topics in our June issue of CRST. And it's available on crstoday.com. Thank you again.
For more shows like the one you just listened to, check out the podcast channel on itube.net.